Welcome. Thank you for joining us today. My name is Amy Samp. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before I get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in reviewing the recording, it will be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you're in listen-only mode. Everyone has been muted so you can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speaker. Joining us today, we have Dr. Jonathan Hausmann. Dr. Hausmann is a pediatric and adult rheumatologist at Mass General, as well as Boston Children's Hospital. He is also an assistant professor of medicine at Harvard Medical School. He completed combined pediatric and adult rheumatology fellowships at Boston Children's Hospital and Beth Israel Deaconess Medical Center. Dr. Hausmann is interested in autoinflammatory diseases, health technology, and medical education. In recognition of Fibromyalgia Awareness Month, he joins us today to give a talk on fibromyalgia. So please join me in welcoming Dr. Hausmann.
Thank you, Amy, for that kind introduction. Now let me just see if I can pull up my slides so that you can see them. All right. Well, thank you all so much for joining. And yes, it is Fibromyalgia Awareness Month. And a couple of days ago, it was Fibromyalgia Awareness Day. So I'll be talking to you about, fibromyalgia, which is a topic that I think puzzles a lot of patients and physicians. So I'll try to clarify, what it is and what you can do about it over the next few minutes. So the objectives are to talk a little bit about how patients present with fibromyalgia. What are the symptoms that are typical of patients with fibromyalgia? I'll talk a little bit about how we physicians make the diagnosis of fibromyalgia. It's really interesting also to understand the history of fibromyalgia and the different names that these diseases have garnered over time. We'll talk a little bit about how pain is generated in the brain for both fibromyalgia and many other chronic pain conditions. And then at the end, I'll focus my discussion on treatment, and especially like evidence-based treatment for fibromyalgia. And I hope that we have time at the end for questions. So if you have questions throughout, please type them into the chat, and hopefully after I'm finished with the presentation, we can discuss some of those questions. So the best way of understanding fibromyalgia is really from the patient perspective. So let me tell you about a patient that I saw a few years ago. Some of her details have been modified to protect patient confidentiality. But her name is Maria, or we'll call her Maria. She's a 38-year-old woman from the Dominican Republic, and she was referred to rheumatology because she had had pain for the last 7 years. She complained of pain in her back throughout the upper, middle, and lower back. She had pain in her bilateral shoulders, especially with activities. Her hands were stiff in the morning, and she endured some weakness. She had a lot of knee pain when she sat for too long. She complained of neck pain. She had belly pain. She had headaches. And at that time, we asked patients to indicate on their intake sheet what part of the body was hurting, and this was her response. So she basically circled her entire body as the sites of pain. We always ask patients about pain severity. So a rating from 0 to 10, how severe is your pain? She said an 8 out of 10. The pain was present all the time. And when she was active, it would increase to a 9. So she was miserable. Her pain all the time was an 8. And then, it got up to a 9. It never got better. In addition to pain, she complained of a lot of other symptoms, including changes in her weight, low-grade fevers and sweats, dry eye, problem with her balance, sore throat, weakness, some hair loss, some tingling, burning, anxiety, depression, migraines, fatigue, problems with sleep. She said she was like in a brain fog. And, rightly so, her primary care doctor over a course of several years had referred this patient to multiple specialists to try to figure out what was going on. So she saw a neurologist and she saw a gastroenterologist, and nobody really could, give her a clear diagnosis as to what was going on. So when I saw her in my rheumatology clinic, I noted that all of her vital signs were normal. All of her joints appeared normal, so they moved well. They weren't swollen. They weren't red. They weren't warm. Um, she was tender throughout. So wherever I pushed on her body, she complained of tenderness. And I had reviewed all of her prior blood work and imaging studies, and it was all normal. So a big puzzle. What is going on here? I think to get a better understanding of what fibromyalgia is good to sort of step back and learn more about the history of fibromyalgia. So the term fibromyalgia is more recent, but we could see in the medical literature that, a couple of centuries ago, there seemed to be a syndrome that was, similar to what we call fibromyalgia today. They called it spinal irritation. At that time, this was in the 1800s, physicians noted that some patients seemed to have very severe pain in the back that was even more severe than people that actually had, fractures of their spine. So it was very severe, but there were no correlates on the physical exam to understand why that was. And then in about a century ago, mostly in France, led by Dr. Jean-Martin Charcot, he termed this condition called hysteria. And hysteria, he coined it as sort of a syndrome that mostly affected women, where they had episodes of fainting or paralysis, they had convulsions and emotional disturbances. And it's interesting, the root of the name hysteria is from hystera, which means uterus in Greek. So physicians at that time thought that this syndrome was caused through problems from either the uterus or ovaries. And, you can imagine what sort of treatments these women received at their hands of their male doctors at the time. And, so that lasted for a while, and then the term hysteria and that syndrome sort of grew out of favor. And, women stopped presenting with these episodes of fainting or paralysis or convulsions. But the term sort of evolved, physicians described similar syndromes with different names, such as neurasthenia, fibrositis, eventually the diagnosis, the name of fibromyalgia, and other related syndromes like irritable bowel syndrome and chronic fatigue. And it's fascinating that, while initially many of these symptoms like hysteria had a lot of paralysis, which was sort of a motor symptom, nowadays, many of these syndromes have a lot of fatigue, which is more of a sensory syndrome. And it's really interesting when trying to understand like how these syndromes come about. So one of the experts in fibromyalgia and other syndromes, wrote something that I think is really interesting. He said, "The unconscious mind desires to be taken seriously and not be ridiculed. It will therefore strive to present symptoms that always seem, to the surrounding culture, legitimate evidence of organic disease. Society does not invent symptoms, it retrieves them from the symptom pool." So what he's saying here is that these women had presented with symptoms that were acceptable symptoms in that culture. So, the episodes of convulsions, paralysis, that seemed acceptable in that day. And it's not that, these women were making it up. As he says later, the symptoms are real, not invented. But the patient must present with symptoms that the medical culture will not reject. So, it's sort of an interesting idea that fibromyalgia and some of these other syndromes are sort of culture-bound syndromes, or partly at least created by the culture. And you might think that this is absolutely bonkers, right? But I can show you that there's many other of these culture-bound syndromes that are more readily acceptable. Let's talk about whiplash, right? Here in the United States, we think that whiplash is the syndrome that happens, often after car accidents, whereby, you're standing at a red light, you get rear-ended, your body moves back and forth, and because of that strain to your body, you strain, some of the muscles and ligaments and tendons in your back and neck, and that can cause lasting pain afterwards, right? That's what we think happens. But when you look at the literature about, who develops whiplash, it's been really interesting to see that in countries with higher litigation rates, so when people sue because they've been hit, they've been rear-ended, the rates of whiplash are increased. So certainly in the United States, in the United Kingdom, in Germany, the rates of whiplash are very high. In contrast, there are countries where there is no concept of whiplash. And so the incidence of whiplash in those countries is very low. So like Lithuania and Greece, they have just as many just as many accidents as we do, but they don't report whiplash because it's not a syndrome that their culture readily recognizes. And what's even more interesting is that in experimental studies, you can provoke whiplash in subjects even when no accident takes place. So what happens is they put research participants into like a fake car, and then they pretend that the car gets rear-ended. So they show bright lights, loud sounds like bang, but the car actually doesn't move. And about a quarter of patients that were in that scenario presented with symptoms of whiplash, even though the car did not move. So, we could see that whiplash seems to be something that it's perhaps created by cultures, and certainly that cultures that seem to have seem to believe about that whiplash exists, or seem to have a reason to have whiplash, like those that have high litigation rates. The experience of whiplash is much, much more common than in cultures where there's an absence of where people don't even know that syndrome should exist. As somebody who grew up in Venezuela, I'm really interested in some of the syndromes that people of Latin America experience. These are described as like a susto. So a susto is an episode of intense fear. And the symptoms that people experience are like diarrhea and fever, loss of appetite, insomnia, mental confusion. And it's thought to be due partly the soul leaving the body when you were scared. There's another one, an ataque de nervios, which is sort of a culturally acceptable response to an acutely stressful experience. So people sometimes have tremors or feeling of heat that starts in the chest and then goes up to the head. People can faint or have agitation. Even they can hear things that aren't present. There's another one, empacho, which is this idea that sometimes food gets stuck to the intestines and causes a lot of bloating and abdominal symptoms, and it needs to be healed with, certain therapies. But of course, this happens in the US as well. I remember about a decade ago in a high school, several students developed sudden, unexplained tics and twitches. So they started moving and then they thought, oh, what's going on? Is there something in the water? Is there, some infection, some pollutant? And it was actually sort of, this sort of culture-bound syndrome that occurred in that particular high school. And it was, called like a mass hysteria or mass, psychogenic illness that they realized was, again, one of these, syndromes that occurred because in that culture, those symptoms were acceptable. So, and I put that there because now I want to contrast this to our idea of fibromyalgia and what it is. Our definition of fibromyalgia has changed over time. In 1990, the American College of Rheumatology did, sort of laid out the criteria for fibromyalgia. And basically, patients had to have widespread pain. So that included you have to have pain on your left side and right side and above the waist and below the waist. And you had to have, these tender points. And you could see this picture on the left of the 3 graces, and they indicate where those exact tender points were so that you could, test it on exam. But more recently, that idea of tender points has fallen out of favor, and the new diagnostic criteria for fibromyalgia has evolved and looks something like this. So just like before, patients need to have widespread pain. So they need to have pain in a lot of areas of the body. And there's actually a checklist to make sure that, if you want to, show that the number of body areas is sufficient. So you need to have widespread pain. You need to have fatigue, waking unrefreshed. So these are patients that no matter how many hours of sleep they get, they wake up in the morning and they still feel tired. And cognitive symptoms. So this is what's sometimes termed as the fibro fog. So patients may have difficulties with memory or difficulties with concentration. And then the last aspect of it is that a lot of patients often have headaches, abdominal pain, or depression. So symptoms need to be present for at least 3 months. And I think one of the mistakes that often happens is that people think that fibromyalgia is a disease of exclusion, meaning, if you have osteoarthritis, then you can't have fibromyalgia. But that's absolutely not true. The diagnosis of fibromyalgia does not exclude the presence of other clinically important illnesses, which is to say that, if you have osteoarthritis or rheumatoid arthritis or lupus or whatever other disease you have, you can have 2 diagnoses at the same time. And important for treatment, you need to treat both. So this is the sort of the diagnostic criteria that physicians look for when diagnosing patients with fibromyalgia. There's other things that give us clues that the patient may have fibromyalgia. This is sort of the review of systems that we typically do. And studies have shown that when people have what we call a pan-positive review of systems, where they have, more than 15 of these symptoms, it's very predictive for the diagnosis of fibromyalgia. So because, often it's not just about having pain, just like the patient that I presented initially. The patients experience a lot of other things that are hard to explain, various sensations and rashes and low-grade fevers that are often common in people with fibromyalgia. Other clues for the diagnosis of fibromyalgia is when people tell you that, or when people experience that some days are better than others, or pain that turns on and off. And this is interesting because when you think about, if you have a fracture of a foot, right? If you have a fracture, pain's going to hurt, and it's not going to matter, the day or the time of day. And it's not something that typically comes on and off, right? If you have a fractured foot, it's going to hurt whenever you step on the foot. But, the pain in fibromyalgia does not behave like that. It often turns on and off. It's inconsistently present. It can be certainly triggered or worsened by stress, or even innocuous stimuli. So, patients may say, oh, when it's hot, my pain gets worse. Or when the wind blows, the symptoms get worse. Or the weather, when the weather turns poor, my pain gets worse. Also, pain that shifts in the location or varies in the intensity or quality. Sometimes it's on the right side, sometimes it's on the left side, sometimes it's on the top of the body or the bottom, sometimes it feels like a tingling, other times it feels like a burning. And another typical manifestation of fibromyalgia is what we call post-exertional fatigue or malaise. And how people experience this is when they engage in a lot of activity. And for some people, that could be going shopping, going to school, going to work. When they come home, they are absolutely exhausted, so that and feel miserable. And that exhaustion and misery, can last for hours, or it can even last for days. Some patients tell me that, after visiting me in my clinic, they need to rest for several days just to recover. So that post-exertional fatigue is very characteristic of fibromyalgia. So what else do we need for diagnosing fibromyalgia? I would argue a physical exam is of absolute importance, right? And what we want to try to do with the physical exam is to see if there may be other contributors to a patient's pain. I'll never forget, a patient that had the diagnosis of fibromyalgia for several years and then came to see me in clinic for a second opinion. And certainly she had all the symptoms of fibromyalgia that I recently discussed. But on her physical exam, her right hip wasn't moving very well. And when she walked, she actually walked with a limp. And I thought there was something going on in the hip. We got hip x-rays, and it was very severe bone-on-bone hip arthritis. And, I referred her to a surgeon. She had a hip arthroplasty, so a hip replacement. And after that, her fibromyalgia resolved. So certainly, as I mentioned before, the diagnosis of fibromyalgia does not exclude the presence of other conditions. So getting a physical exam to see if there's elements of osteoarthritis or rheumatoid arthritis, or other causes that may be contributing to the pain is very important. Blood work, again, it's not required. Sometimes we get blood work because, for instance, if patients are fatigued, is that fatigue because of the fibromyalgia, or maybe they're just anemic? Similarly, maybe their thyroid isn't working very well. Sometimes we think about getting inflammatory markers. That can be helpful if we think, in addition to the fibromyalgia, the patient may have an inflammatory arthritis like rheumatoid arthritis, but it's certainly not required. And then, we think about imaging studies, and the thing about imaging studies is they need to be interpreted with caution. For instance, if you get an MRI, let's say you have somebody with back pain, with chronic back pain for 10 years, you get an MRI of the back, you will invariably see changes in the back, and you'll say, oh yes, some of the areas here, there's a little bit of degenerative changes. Maybe it's some of the vertebra, um, uh, there's some disc disease, and where physicians very readily interpret any imaging finding as the cause of the patient's pain. But in most of us, if we've been alive for any time, we get images of the joints. They're not going to be perfect. And the thing is, a lot of people without back pain have abnormal MRIs of the back. Similarly, with our peripheral joints, if we get, images of the knee, and it shows a little bit arthritis, we're always quick to say, well, you have arthritis of the knee. That's why you've had knee pain for the last 10 years. And it may not always be the case. So let's talk a little bit about sort of the epidemiology. So looking at the big picture of fibromyalgia and how common it is. In the United States, it affects 2 to 4% of the adult population. It's certainly more common in people with rheumatic diseases. So in people with rheumatoid arthritis or lupus, it may be up to 30% of patients. There's still a female predominance to the diagnosis of fibromyalgia. Currently, it's thought to be 2 to 1. It's interesting that when the diagnosis required the tender points, the ratio was 10 to 1. So many more women or many fewer men were diagnosed when tender points were required. Now that tender points are no longer required for the diagnosis of fibromyalgia, we're diagnosing many more men with this disease. As a pediatric rheumatologist, I certainly see pediatric fibromyalgia. Sometimes we call it pain amplification syndrome in children. And certainly I see it in my older adults, and I see it, everywhere in between. And triggers for fibromyalgia, are many. It can include, acute pain. So let's say you fracture your foot, that might be the thing that kicks off this whole cycle of pain. Infections, whether it's Lyme disease, strep, EBV, COVID-19, all of these can be triggers. Trauma, war, I see many patients that immigrate to the United States, and that stressor may also be a trigger for fibromyalgia. So risk factors, history of psychiatric illnesses like anxiety, depression, OCD, post-traumatic stress disorder, adverse childhood experiences, and interestingly, family histories of pain. So especially in the children that I see with, the equivalent of fibromyalgia, there's often a family history of somebody with a chronic pain syndrome, whether it is, sometimes fibromyalgia, sometimes it could be chronic back pain, or other pain syndromes. So in children, especially, the pain behavior, it's learned. And, in addition to fibromyalgia, a lot of patients that eventually get diagnosed with fibromyalgia have long histories of chronic pain syndromes, such as headaches or dysmenorrhea, TMJ disease, chronic fatigue, irritable bowel syndrome, interstitial cystitis, endometriosis, and other regional pain syndromes. As I mentioned before, many patients with rheumatic diseases develop fibromyalgia, and it's thought that the inflammatory response from like rheumatoid arthritis sensitizes the nerves to increase pain sensitivity. And that may be a risk factor for fibromyalgia. And lastly, things that are modifiable. So we'll talk a little bit more about sleep later, but poor sleep is a huge risk factor for developing fibromyalgia. If any of you have gone 24 hours without sleep, like many physicians do when they're on call, you're going to be achy the next day, right? And you do that for several days, and you can develop fibromyalgia just from interrupting somebody's sleep. Obesity, physical inactivity, and poor job or life satisfaction have been found to be risk factors for fibromyalgia. Now let's switch a little and talk about like what's actually happening in the brain with fibromyalgia. Our concept of what causes pain has really changed, over the last decade. So I'll give you an example. Let's say, total hypothetically speaking, that you are skiing with your daughter in New Hampshire after it rained the entire day and it froze overnight. So the slopes are very, very icy. And you fall and you hear a pop from your shoulder. Those signals are immediately going to go to the brain, and the brain is going to try to understand and interpret what those signals mean, right? So in this case, the poor father heard a pop. Maybe he's a physician. Maybe he thinks, oh my goodness, I think I just dislocated my shoulder. That must be painful. And the brain is going to say, oh yeah, that's painful. Dislocating the shoulder is very painful. There's the injury. Let's cause pain, because pain is important to try to protect the injury, right? Because if you move it anymore, you might cause even more damage. So the brain sends pain signals to try to protect you. So in this case, pain is a protective mechanism to prevent further injury. And, the brain is pretty smart, because if it thinks that a part of your body is in danger and needs protecting, like a dislocated shoulder, it will make that part of the body hurt. And evolutionarily, that makes a lot of sense. And in this case, pain is a symptom, right? Pain is a symptom of a dislocated shoulder. And fortunately for most of us that have injuries such as this, the injury eventually heals and the pain resolves. Unfortunately, in some people that have had injuries, the injury heals because in general, almost everything heals over time. So the injury heals, but the brain is still sensing pain from that area. And how this happens is, it's amazing. So the pain is no longer a representation of what's happening in the joint, because the joint has healed. And when researchers look at what the brain function is doing, they've shown that the pain signals, with the acute pain, shift to parts of the brain that are more related to emotion, like the medial prefrontal cortex and the amygdala. So the acute pain in people that continue to have pain, that acute pain shifts to a different part of the brain that's related to emotion. And it's that part of the brain that maintains the symptoms of pain. So in this case, pain actually becomes the disease. The tissues have healed, but the pain is still there. So pain becomes the disease. I think, we used to think that pain was sort of an objective indicator of damage. And now we know that pain is much more complex than that. So let's put some facts out there on the table. Pain is a construct of the brain in response to signals from the body. So pain is entirely subjective. And this is for every type of pain. I remember a few months ago, I had a steaming cup of hot coffee, right? You could see the coffee, steam coming from it. And I was with my daughter, and she was seeing the steam. And then a few minutes later, her arm brushed against my cup and she screamed in pain. Ah. I'm like, what happened? I burned myself with your coffee mug. And I wondered, but the coffee mug is not hot. How did that happen? And what's interesting is that, she thought that because the coffee inside the mug was hot, the mug was also going to be hot. And by touching the mug, she would get burnt. But when I asked her to go, no, come back. The mug is not hot. She touched it. She was so surprised that the mug was just, barely warm. And what this shows is how the brain can modulate the sensation of pain. If you think that something is going to hurt, guess what? Your brain is going to make it hurt, even if that something is something that's benign, like a warm cup of coffee. And any credible evidence of danger to the body will modulate the pain, so that if your body thinks that it is in danger, pain will be heightened. If your body thinks that it is safe, pain will be lessened. And the unfortunate part of pain is that if those brain networks that are sensing pain continue to get activated, they become better and better at producing pain. So in the future, just a small stimulus to the area will cause a lot of pain. And if you continue to keep that going, the pain actually begins to spread to other areas, because those pain networks lose the capacity to be precise and specific. So over time, people can experience pain in more and more areas of the body. And how you think about your pain can actually change the way it feels. So if you feel like your pain is because you have a damaged joint, and it's dangerous to put your weight on it because you're going to damage the joint, pain is going to go up. If you tell yourself that, that chronic pain is just your brain mistaken sensations for pain, and that it is not dangerous, guess what? That pain is going to go down. So that's a little bit about the physiology of pain and sort of the experience of pain. And, pain is in your brain, right? So it's in your brain. Pain is real, but it is a product of the brain. It is not a product of the body. So when people say, well, pain is in your head, well, yes, you're not making it up. The pain is real, but the pain and pain signals and the pain experience comes from the brain. So let's turn over a new leaf and talk about some evidence-based treatment for fibromyalgia. And certainly, I can tell you this is one of the most challenging conditions that we treat in rheumatology. We have very good medications for arthritis and lupus, and for vasculitis and other inflammatory diseases, but the treatment of fibromyalgia is pretty challenging. I think the first thing to do that is important is to make the diagnosis of fibromyalgia. For patients, not knowing what's causing all the symptoms can be incredibly frustrating and stressful, right? So for a lot of patients, they think something is wrong and people just aren't finding it. It may be they often worry that they have cancer, or they have some undiagnosed condition. And that anxiety, can increase the pain signals. So by explaining to patients about what fibromyalgia is, studies have shown that people get a little bit better. So they start having fewer symptoms. They start seeing their doctors a little bit less. They start getting fewer MRIs and CAT scans and ultrasounds and blood work to try to figure things out. And the important thing to do is once the diagnosis of fibromyalgia is made, to focus on treatment, not further workup. I think patients with fibromyalgia experience a lot of symptoms, and trying to chase after every one of them, if they have a headache, do you get a brain MRI? If they have belly pain, do you get a colonoscopy, an endoscopy? That can sometimes cause more anxiety and more harm. So I think, making the diagnosis of fibromyalgia and focusing the medical care on treatment is essential. Other things that are important is that have been found by the literature is aerobic exercise. Now you'll ask, but wait a minute. Didn't I just say that patients who overexert themselves experience a lot of fatigue and malaise? It's like, yes, that's true. But that doesn't mean that they shouldn't or can't exercise. And the trick with aerobic exercise is starting little by little at a time with a physical therapist that's comfortable in managing fibromyalgia. So yes, if you go out into the gym and you hit the treadmill for 30 minutes, you're going to be in pain and miserable, and you're never going to want to go to the gym again. But let's say you hit the treadmill for just a minute, and then you leave the gym, and then you do it again, but for 2 minutes, and then you leave the gym, and then you do it again for 3 minutes, and you slowly build up your tolerance. Then you can achieve, aerobic exercise, and when you do that, the body releases these natural hormones that and endocannabinoids that actually help to take pain away, help to make you feel good, and help improve your sleep. So aerobic exercise is essential. And all the studies show that it improves your function, it decreases pain, it decreases fatigue and stiffness, and the benefits continue even after the intervention in the study stops. Which is not to say that you should stop exercising, but it's to suggest that it starts off this pathway that makes people better over time. But as you can see here, the degree of benefit is moderate. So, even if you engage in aerobic exercise, it's not going to cure your fibromyalgia. Other things that have been shown to help fibromyalgia based on, many randomized studies. I think some of this was from over 2,000 patients, and 30 trials have shown that cognitive behavioral therapy for fibromyalgia is effective in reducing pain, reducing disability. And even after the intervention was stopped, people continue to experience that benefit. And what cognitive behavioral therapy does is try to sort of change those automatic thoughts that you have, like, oh my God, I'm in pain. I'm always going to be in pain. I'm never going to feel good. And it asks you to sort of question those automatic thoughts to see if they're actually true. Other interventions that have been found to work, this is from colleagues at Tufts University, is Tai Chi. So Tai Chi is this mind-body intervention that integrates both physical, psychosocial, spiritual, and behavioral elements to promote health and fitness. And they did a really nice randomized trial with several hundred patients with fibromyalgia. They gave them, Tai Chi or aerobic exercise. And, what they found is that Tai Chi is at least as good as aerobic exercise in decreasing the symptoms of fibromyalgia. Depending on how often Tai Chi was done, some people actually did much better than with aerobic exercise. So Tai Chi is something that can be implemented as part of the treatment of of fibromyalgia. You know, we talked a little bit about sleep, right? Unrefreshing sleep and fatigue, and so there's a lot of interest in trying to improve sleep. And the question is, do patients with is the fibromyalgia causing people to sleep poorly, or when you sleep poorly, do you develop fibromyalgia? And I think actually both of those things are true. Certainly, as I mentioned before, if you have lousy sleep, like, parents, for instance, who have young babies, if you have lousy sleep, you're going to be achy. And studies have shown that patients with fibromyalgia have objectively abnormal sleep patterns and shorter sleep durations than people without fibromyalgia. So of course, there's thinking, well, can we help improve sleep and thereby improve some of the symptoms of fibromyalgia? And, the answer is yes. So some interventions like this thing called cognitive behavioral therapy for insomnia, or CBTI, was found in one study to decrease pain, both subjectively, so decrease the experience of pain, and when they do functional MRI studies, decrease pain sensitivity in brain regions associated with pain. The Department of Veterans Affairs, the VA, has created actually an app, which is called CBTI. Here's the icon here that you can download for free, and can be helpful to addressing some of the aspects of the poor sleep in fibromyalgia. And what's also interesting is that a lot of patients with fibromyalgia may have obstructive sleep apnea. So that means that when they're sleeping, because of issues with anatomy or with weight, they block their airways and sometimes experience, apnea. So episodes where they're not breathing and they're not getting oxygen to the body. That kind of sleep is not very restful. So a lot of people with fibromyalgia have obstructive sleep apnea, and therefore by fixing the obstructive sleep apnea, whether if you wear one of these masks like a CPAP mask, or sometimes they have these dental devices to help improve the shape of the mouth and keep the mouth opening when you sleep. A couple studies have shown that it may help improve fibromyalgia symptoms. And I think the coolest and most novel treatment for fibromyalgia is something that's called pain reprocessing therapy. So recall that pain is the body's signal that you are in danger, right? That a part of you is in danger, that your shoulder is dislocated and you should move it. And the whole point of pain reprocessing therapy is moving you and your brain from a sensation of danger to one of safety. So that has pain reprocessing therapy has 4 components. The first one is reattribution of pain to non-dangerous, reversible mind or brain processes. So instead of thinking that your knee hurts because you have arthritis in the knee, or your back hurts because there's abnormal signals on the MRI, or there's degenerative disc disease, or that your belly hurts because you think you may have a cancer or tumor. It's important to reattribute the pain and say, no, I feel the pain in all of these areas. The pain is very much real, but it is actually due to how the brain is interpreting signals coming from that body area. The sensation of pain and why I'm feeling pain, it's not dangerous. So you need to sort of reattribute the pain, instead of saying, oh, it's because I have injured tissues or something that's happening, in the periphery, in the body, to processes that happen in the brain. The second aspect is trying to reduce that fear of pain. So when you're afraid of pain, right, and when you're just fearful in general, the pain is going to be elevated and it's going to be magnified. And therefore, when you're your fear lessens, the pain can get better. So they talk about somatic tracking, which is, can be done in various ways, such as guided meditation or mindfulness, or you make an evidence, for and against why you think, the symptoms that you experience are dangerous or not. So, make a list, why you think they're dangerous, and then on the other side, why you think they're not dangerous. And practicing this over time, you'll gain evidence that, maybe some of these things are processes of the mind instead of something structural in the areas that hurt. And then something that's very important is try to do the behaviors that you think will cause pain. So, what often happens with a lot of patients with chronic pain syndromes is that they stop doing things. So, I can't go swimming because my back is going to hurt. I can't sit for too long because, my back is going to hurt, or I can't climb stairs because my knees are going to hurt. And the more fear that you have and the more you avoid doing those things, the worse your symptoms will be, and the worse will the pain that you will get. So actually doing some of those behaviors that are scary and seeing, wow, okay, that was mildly uncomfortable, but I was able to do it. That can actually help to rewire the brain. And then you try to address, what they call here non-pain threats. So, things that are stressful in your day-to-day that may be augmenting your sensation of pain. So, you know, trying to think about your relationships, try to think about, your work situation, and try to reduce some of those stressors, because, that those stressors in the environment can certainly heighten your pain sensitivity. The researchers did a really nice study using pain reprocessing therapy to treat 50 people who have had like chronic back pain for 10 years. And when they gave them, this 4-week intervention of pain reprocessing therapy, you notice here how the pain intensity decreased significantly in people that had pain reprocessing therapy. And what's, I think, still amazing is that in those people that had chronic pain for 10 years, and that all had MRIs that show that, oh yeah, there's abnormal signals here, almost 75% of them were pain-free or nearly pain-free after this mind-body intervention. And even after a year, half of them still remained pain-free. So this is, the best therapy for chronic back pain that I've ever seen. And I think it can be applied to fibromyalgia as well. So how do I treat fibromyalgia? Well, patient education, which is a lot of what I'm doing today. We certainly talk about stress reduction techniques, whether that's, CBT, Tai Chi, acupuncture, massage. Certainly if patients have depression or anxiety, those should be treated with the help of a mental health counselor or psychiatrist. We talked about aerobic exercise, and I think the goal I always tell patients is to get at least, 30 minutes of aerobic exercise, at least 3 times a week, and the more the better. But working with physical therapy can be really important to get patients started because, of that fear. And sometimes you get the opposite problem, especially in people that were formerly athletes. They're going to say like, I'm going to hit the gym, and they go on their bike for like an hour and then they feel miserable and they never want to return to the gym again. We talked to the importance of sleep. I think getting a regular sleep schedule is important. Thinking about a sleep study, especially if there's any snoring, and that app called CBTI can be helpful. Certainly we want to exclude other contributors to pain, such as osteoarthritis or rheumatic diseases or anything else. And if those are present, treat those, at the same time that we treat the fibromyalgia. Medications are usually sort of the first thing that patients and physicians think about when treating fibromyalgia. And, I put it here last because it's certainly not. They can be helpful for some patients. I think amitriptyline is pretty good. I think that's the one that I've found patients do best with, but gabapentin, pregabalin, duloxetine, or Cymbalta can be tried as well. But by themselves, they're going to have very, very small effects. And then, of course, we just talked about pain reprocessing therapy that I think can be a helpful add-on to the treatment. Just as important are things to avoid. So opiates, right? Like OxyContin, oxycodone, all of those opiates actually paradoxically increase pain sensitivity and make people much worse. We talked about the danger of more diagnostics. I think that just creates more anxiety and more pain. Surgery is almost never the right answer in patients with fibromyalgia. They've shown studies that if you have like osteoarthritis and fibromyalgia and you get like a knee replacement, those patients do much worse than people that don't have fibromyalgia. And, I try to avoid filing for disability because I think fibromyalgia is something where people can actually get better. And filing for disability basically suggests that this is untreatable and patients have no hope for recovery. So I think that's not true for most patients. Local resources, you might think, well, I'll just refer patients to Dr. Hausmann. He seems to know what he's doing. But, unfortunately, our rheumatology office actually does not manage patients with fibromyalgia. We have, if your doctor tries to refer you to rheumatology, there's a pop-up that says we don't manage fibromyalgia. And that's because, there's a lot of patients with inflammatory conditions that we are the only ones that are adept at treating. And there's not enough of us to go around to treat those patients and people with fibromyalgia. So where can you go? MGH has the Benson Henry Institute for Mind-Body Medicine. There's the Center for Pain Medicine in Waltham. Spalding has a wonderful pain management program in Medford. Wentworth Douglas Hospital has a Center for Pain Management, and they all treat fibromyalgia. I think learning about pain reprocessing therapy is really important. If you're interested, there's great books like The Way Out by Alan Gordon. He was one of the people responsible for that back pain study. Unlearning Pain by Howard Schubiner. He was also part of that study as well. There's podcasts. If you like, I did a podcast with Dr. Schubiner called The Science Behind Reprocessing Pain in ACR on Air. And Ezra Klein, if you like him, he has a podcast titled This Book Changed My Relationship to Pain, which is very good. There's apps, movies, and whatnot. So for my patient with pain for 7 years, what's going on? I think we diagnosed her with fibromyalgia, provided patient education, referred her to physical therapy and mental health counseling. So the take-home points is about how we make the diagnosis of fibromyalgia, the symptoms that patients experience, thinking that only a limited workup is necessary, and the various treatment options. And I think it's very important to provide patients with a lot of treatment options because no single treatment will be effective for every patient. Thank you for your attention and happy to take any questions.
Thank you. We do have a few questions. One person is asking, is fibromyalgia a functional disorder of sorts?
Yeah, so a functional disorder is it's another way of saying get diagnosed with like a functional abdominal pain, and they may have fibromyalgia. So I think that's another way of putting a term to what fibromyalgia could be.
Thank you. And are there any objective tests for this disorder? It seems like, it sounds like a diagnosis through exclusion.
Great. So, again, I would make the point that it's in a diagnosis of inclusion, meaning that you have to have certain symptoms and to meet the criteria for fibromyalgia. certainly, if you look at a functional MRI study in somebody with fibromyalgia, it's going to look different than somebody that doesn't experience fibromyalgia. So which is to say that patients with fibromyalgia may have objective findings, whether you do a exercise study or whether you do a functional brain MRI. So they have objective findings. So, their symptoms are real. But we typically don't do those studies for diagnosis. How frequent is fibromyalgia in children? That's a great question. It's unclear. We certainly see it in rheumatology. I mean, one of the most common complaints that patients present with in rheumatology is joint pain. And some of those patients are going to have, fibromyalgia. I can't tell you the name, but the percentages, but it's fairly frequent in children that have chronic pain.
Thank you. And do you have time for one last question?
Sure.
If pain's a disease, what is medicine doing to interrupt this learned pathway?
Yeah, great question. So some of the medications like the tricyclics like amitriptyline, pregabalin, gabapentin, what they are thought to do is they work on the nerves. So they help to sort of decrease the volume of pain that happens. So, patients with and again, I stress it, patients with fibromyalgia have objective findings, objective changes in the way that their brains are working and interpreting signals. So, to address some of those things, medications can be somewhat helpful, but they are only a piece of the puzzle. Just by treating patients with medications, their fibromyalgia is not going to go away.
Wonderful. We are at time. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
Yeah, I thank you for the opportunity to talk about this, puzzling syndrome. I think it's challenging from a patient perspective to, feel all these different symptoms throughout the body and not have a good understanding of what's going on. It's certainly frustrating from a physician perspective because we have patients, that present with all of these symptoms. And if you're not knowledgeable about the diagnosis of fibromyalgia, you can spend a lot of time and a lot of money trying to work up each one of the individual symptoms, and you sort of miss the forest for the trees. So I think patient education is important, physician education is important. And again, focusing on the treatments of fibromyalgia, which I mentioned, rather than further diagnostics, I think can be very useful.
Thank you. Thank you so much for spending the hour with us. This is extremely helpful.
Thank you.
And for everyone who joined today, thank you for joining. As I had mentioned, today's session is being recorded. It'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.